The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to focus on pediatric DKA management. You know, oftentimes when I reflect on education and I reflect on teaching endocrine emergencies, we talk about adult DKA patients, the management of those patients. We don't really focus on pediatric DKA, and pediatric DKA can be a more difficult type of disease to, number one, recognize, and I say that from the parent standpoint, and number two, from a treatment standpoint, it can be a little different than adults, and so we definitely need to treat pediatrics differently in the management. The recognition really is one of those things. It's, you know, they're young, they're healthy. It's easy to miss those clues, especially if this is a new onset DKA, which a lot of these patients that are diagnosed with type 1 diabetes, the diagnosis is based on really them going into DKA, parents transporting them to the hospital, and the diagnosis being made at that point. So really what this podcast is about is think about critical care transport. Think about you having to transport a DKA patient. You're not going to transport these patients from pediatric facilities, level 1 facilities. These are going to be patients that come from critical access areas, or maybe even a 911 call where you arrive on scene. And there's some key areas of treatment that really are different than in the adult population that we have to be very careful of. And so that's where we're going to look at really resuscitation from really that 1 minute mark until that 1 hour mark, right? That's going to be from a pre-hospital standpoint, those paramedics out there transporting. That is very, very important. That is a very important resuscitation area that we want to be careful of. And then what happens from that 1 hour mark to that 4 hour mark? That's a phase 1 treatment approach. And then everything after 4 hours is going to be a phase 2 approach. So from a HEM standpoint, or even critical care ground, you're going to have these patients in these critical access areas. Now, the other thing that we have to understand is critical access hospitals are really the heartbeat of our communities, our rural communities. We have to have them. We have to have those places to take our loved ones. But you're not going to have the same level of care in some of these difficult areas like pediatric DKA, where a children's hospital, level 1 children's hospital, has very strict guided protocols for pediatric DKA because there's so many areas that have to be covered, and you have to be careful, and it's very easy to, manage these patients incorrectly. So that's one protocol in these pediatric facilities that are very, very strict. There's no deviation from. Obviously, all the physicians come together. They joined and they come up with a consensus approach. And so there's never going to be an exact algorithm that every pediatric facility in the United States or around the world, uses. There's going to be some variations. But really, from the pathophysiology standpoint, those areas are very sound. And really, the areas we're going to touch on, I feel, based on the evidence, are standard treatment approaches that we have to be careful of. So let's start in. We have an 8-year-old male that parents state over the last week has not felt well. Really, they felt like he might be in more of a flu state, maybe mild cold, but then he started getting better pretty quickly. And so we'll just say he's on and off. He just doesn't feel good, and then he's more active, and then he doesn't feel good. And so that's gone on for about 5 days. And then day 6, he starts feeling and complaining of some nausea and vomiting. And he's vomited 3 times in the last 24 hours. They did put him to bed a little early the night before, and he wakes up the next day. He is just drowsy. He's not as vibrant as he normally is. He's pale. Wouldn't say he's hard to arouse, but he just doesn't want to get out of bed. And so mom obviously is worried. Mom and dad decide, hey, let's take him into the ED. And they enter into the ED based on just POV transport. Initial triage is done. His initial assessment, he's alert. He's oriented times 4. He does, answer questions appropriately. Vital signs currently: blood pressure 108/68, heart rate's 120, respiratory rate of 28, and he had an SpO2 currently of 95%. They did take him into the back, and they have established 2 IVs at this point. They get a patient weight. He currently weighs 80 pounds, which equates to 35 kilos. But mom and dad immediately start discussing this with a physician, say, he just got done playing football. He was being weighed every single week before the games, and he is about 10 pounds lighter now than he was during the season. Labs were drawn. Labs come back: sodium of 125, chloride of 87, has a current K of 3.1, and a glucose comes back at 389, lactate of 4, and they do draw for ketone bodies. And so remember, the early ketone bodies that we can identify very quickly and is very accurate is beta hydroxybutyrate. We did a podcast on that a couple years ago. It comes back at 2.1 millimoles per liter. So when we look at just the information we have right now, is there any indication that this patient is in a DKA state? Well, there are definitely some clues that will go back to, any child that has, that general illness that's extended, and, nausea and vomiting, that's a lot of times can be associated with ketone production. And that's something that will also make adult patients nauseated. And so, but really when you look at this from just the standard illness, it's easily attributed as the flu. And that's the key. Also, the weight loss, right? Are you going to notice a weight loss like that? You may or may not notice that because you're around that child every single day. Other clues, does the child always state they're hungry? Do they pee constantly? Are they constantly peeing? Has that been a change? I've had friends that have had new onset type 1 diabetes that really had no clue, right? Initially, they didn't really think anything about the weight loss or the excessive urination. So a lot of times it sneaks up on us. We just go through our everyday lives, and that's no different for our kids. So how do we define DKA? Well, a glucose greater than 200 milligrams per deciliter is a good start. And some protocols I've seen, it's as high as 300. But for this podcast, we're going to say 200 milligrams per deciliter. Definitely checks that box. Does he have any ketone production? And so again, beta hydroxybutyrate greater than 1 millimole per liter. And we can check that box as well because he's at 2.1. And then when you look at a pH, is the pH less than 7.3, or do you have a bicarb less than 15? And so the doctor did order an ABG. ABG comes back. We have a pH currently of 7.10, PaCO2 of 24, bicarb of 13, PaO2 of 128, and a base excess of negative 12. So if we break down that pH really quickly, because we're less than 7.35, we're uncompensated. Again, if we were greater than 7.45, we'd also be uncompensated. And because we're also less than 7.4, we'll say 7.4 is a perfect pH. Anything less than 7.4, we would say acidemia. So right now, just based on the pH first and last name, we're looking at an uncompensated acidosis. I always go then to my bicarb. I want to know if my bicarb is altered. We know if it's greater than 26, that is going to be a reflection of alkalosis on the metabolic side. If it's less than 22, that's a reflection of acidemia on the metabolic side. And we're definitely less than 22. We're at 13. And that also fits that criteria of DKA, the bicarb being less than 15. And so based on that, we know if the kidneys are reflecting acidemia, our body's buffering systems kick in. Respiratory is always going to be the last line of defense. And it recognizes, hey, we've got all this hydrogen ion, all these protons. We also have all this CO2. And really, bicarb is a fancy CO2 carrier. The majority of CO2 is carried within bicarb. And if you don't remember how that works, it's based on the acid-base formula, right? The CO2 carbonic system shifts the CO2, combines it with water, forms carbonic acid. Carbonic acid splits apart into bicarb and hydrogen. Well, the lungs take that excess bicarb and hydrogen, and it moves it the opposite direction. It combines them again together. Carbonic acid is formed. Carbonic acid never stays as carbonic acid. It splits apart into CO2, which can be exhaled, and water that is then evaporated. So if we go to this patient's vital signs and we look specifically, well, BP right now is 108/68. Again, heart rate 120, respiratory rate of 28. So he's a little bit tachypnic. SpO2 95%. Again, we got 2 IVs established at this point. Blood pressure is normal. We always use the 90 plus 2 times the age, and that's, a great number. So, 90 plus 2 times the age, he's 8 years old. So 90 plus 16, 106. So his systolic is where it should be. His heart rate's probably a little high, but we know that kids and adults both become a little bit volume depleted in DKA based on that excessive urination. So when we think about this ABG again, pH is 7.10, we have our bicarb of 13, again, uncompensated metabolic acidosis, but because the buffering system, the respiratory side, is kicking in, that is showing alkalosis. Our CO2 is 24. So always remember, if your kidneys are showing acidemia, your lungs should be showing alkalosis. And that's exactly what we see. We're in a partially compensated metabolic acidosis. And that is nothing that would surprise us. We should expect this type of ABG. So where do we go from here? Where is this? Let's say this is a 911 call. Are there clues that can guide you to say, hey, maybe this patient is in a DKA? Well, absolutely. If this patient, like mother and father states, has no medical history, no type 1 diabetes, and you check a capillary blood glucose, you should always be checking glucose levels on kids, and it comes back at 389, that is a red flag. And so that, for me, would be the time to kind of stop and reset your mind and go, okay, how are we going to approach this? He has no history of type 1 diabetes, no history of anything related to any other anomalies with blood sugar levels high or low. What is the cause? Are you going to always smell that ketone smell, that fruity odor on the breath? Absolutely not. Some of us can't smell that. A lot of us can't smell that. So don't always think about that. That's more of a textbook type of an approach. How do we approach pediatrics from a resuscitation standpoint? What is our normal approach? That's where we can maybe go down the wrong road in these patients. And we've all been trained, it's just been hammered into us that kids need fluid, kids need fluid, kids need fluid. We have a patient that has a BP of 108. Systolic is fine, but a little bit tachycardic. And we know that that is normal compensation. Why is this patient tachycardic? So common sense says, hey, this patient is volume depleted. We need to give some volume. Well, we would always go 20 mils per kilo for any pediatric greater than 30 days old. And in a DKA patient, that is a common mistake. That's where we have to stop. We have to understand that that is going to cause the patient potential harm. So why is this such a big deal? Why can't we go 20 mils per kilo like we would on a normal kid? And again, remember, these kids have ketone production, and ketone production is an essential fuel energy source for these patients. In pediatrics specifically, when you compare them to an adult, the pediatric brain actually uses 5 times the amount of ketones as a fuel source than adults. And so when you think about giving them all this volume, if you turn off that ketone production or that ketosis, if it's too quick, essentially what you've done is you've caused the well to become dry, and the brain will then swell and cerebral edema will ensue. And that is really the big complication that we want to stay away from. We don't want cerebral edema. And we're going to go through in later parts of this podcast, really the areas of concern, what could cause us to see a potential cerebral edema type of a situation. But I can't stress it enough. You've got to have a high index of suspicion, right? Go back to the symptoms, go back to the long illness state. Question even further back. Has the patient shown any signs previous to 5 days? Has the child had weight loss? Like, get into that routine of using differential diagnosis. But again, you check a glucose and it comes back at 386, 389, 400. Well, ding, ding, ding. That is going to tell you this patient potentially is in that DKA state. And that's where you start questioning, hey, does this patient have type 1 diabetes? Mom and dad says no. Well, you know this patient is likely in a new onset DKA. So how do we approach that initial phase, which we would say is phase 0? So we'll say from 1 minute to that first hour. And that's where we have to go back to really just the concept of how would we deal with a neonate? Well, a neonate, if they need volume, is going to get, a 10 mil per kilo bolus. And so in this type of patient, you're going to use normal saline and you're going to do a bolus over an hour. Really, it's 10 mils per kilo over an hour. And the key here is in the adult patient where you might bolus them with insulin and start that insulin immediately and then follow that up with a drip. In pediatrics, you absolutely do not ever start any insulin prior to that first fluid administration phase. You would also evaluate that K, and we know this patient's K was 3.1. So the protocols usually say if the K is less than 3.5, you would start potassium in conjunction with that initial 10 mil per kilo over 1 hour fluid administration phase. Again, no insulin whatsoever. And to, really couple on that, we're going to talk about really the insulin administration later on. There's never any bolus of insulin prior to that maintenance infusion of that insulin dose. So then what is really our treatment guideline? What would we go to from a treatment standpoint? Again, high index of suspicion. You're like, okay, sugar is 389. I know that initial phase 0, that 1 minute to 60 minute phase is imperative as far as what we do from a volume standpoint. We don't want to get rid of that ketosis. We don't want to cause that well to go dry. We want to allow for the ketone production to continue. And we know that the brain in that pediatric patient uses 5 times the amount. So how do we approach that? Well, we're just going to simply do a 10 mil per kilo fluid maintenance infusion. Normal saline is fine over 1 hour, 10 mils per kilo. We're not doing 20 mils per kilo. If the potassium is evaluated to be less than 3.5, we're going to add K on top of that in that initial fluid bolus. Now, the really, really important part here, and if this is a 911 call, we're not going to do this. We're not going to see this, but I definitely could see this in a critical access hospital or, could a flight team implement this? We absolutely never want to start insulin on these pediatrics until that initial fluid bolus phase is over. So they need to have that 10 mil per kilo initial volume. Again, if the K is less than 3.5, we would start K but insulin should never, ever be started. We want to wait until that phase 1 area. And that is definitely different in the adult population. The other difference we're going to see when we really dissect the insulin is there's never any boluses of insulin. It's only that infusion, ongoing infusion that we're going to focus on for our pediatric patients. So as we continue our care, again, that first phase 0 area really from a 911 standpoint is going to be where we would really focus our attention. Well, let's say this patient is a transfer critical access hospital, whether you're a HIMSS crew, flight crew, or critical care ground crew, or really an ALS crew that's transferring a patient, right? It doesn't have to be critical care. What do we see in phase 1 of these protocols? Again, these protocols may not be implemented. And so a good understanding of really where that phase 1 approach is going is essential. And so most of these protocols will have a 2-bag system. Essentially, 2 bags are going to be running simultaneously, and they are using each one from an identical electrolyte standpoint. But one bag will contain usually a 10% dextrose or D10 solution, and the other one will not. And really the thought behind that is it gives the bedside provider, whether you're a nurse or a paramedic, a flight team, the ability to adjust the infusion rate of each bag to address fluctuations in the patient's glucose level without really altering the insulin rate. And so the insulin obviously is starting at this point as well. And we know the insulin is super essential in this whole process. And I think that's a big area of focus is think about that. We're not altering or changing the insulin infusion rate. We're simply increasing or decreasing the dextrose level based on our serial glucose evaluations. So how do we then move past that phase 1? As we said, it's all about making sure we have a fluid that is comprised of dextrose to where that maintenance infusion can be titrated up or down instead of insulin. So that is a key area. But then when you get into really further evaluating how fluid management is done, they have a lot of these protocols have a 2-bag system. And that 2-bag system really starts with normal saline as a base. And then they add a lot of times 20 milliequivalents per liter of potassium phosphate, and then another 20 milliequivalents per liter of potassium acetate. Now, when you look at really the K, remember this patient's K was 3.1. We started K early on, and potassium is going to continue in these patients unless they're in a hyper K state. And so most protocols state that if potassium is greater than 5.5 milliequivalents per liter, you would continue with potassium within your fluid management. And as I said, there's a 2-bag system in this phase 1, and that secondary bag has that dextrose component to it. Now, one of the things I didn't really allude to earlier was, well, is that on every single patient? And as I said, that dextrose, that 10% dextrose is all about titration. It's all about up and down to make sure our glucose doesn't fall too quickly. Most protocols have a stopgap to where you don't want to drop that sugar more than 100 milligrams per deciliter per hour. Some of the HIMSS protocols I've seen or worked under have been more conservative at no more than 150, or when you look at it, more than 50 in 30 minutes. But really, this second bag is started in most of these protocols if glucose is less than 300 milligrams per deciliter. Now, we know that this patient came in at 389. And so based on that evaluation, serial glucose levels are going to have to be done every hour. And if that glucose is less than 300, then that second bag, again, that 10% glucose will be started. And it's going to have, again, that 20 milliequivalents of potassium phosphate, another 20 milliequivalents of potassium acetate as well. If we come back to the insulin, remember insulin is so essential in this patient. We did not give any bolus dose of insulin. We did not start insulin prior to any of that initial 0 to 60 minute phase 0, I should say, time frame. But kids do not need a bolus. And so really that insulin drip is going to be, standard. We always talk about 0.1 units per kilo per hour. It could be 0.05 or even 0.025 units per kilo per hour. But that's going to be based really on that ketone production and really the age. A younger child, a younger pediatric, we'll say less than 5 years old, has higher sensitivities, right? And again, we come back to, well, what are we worried about? We're worried about cerebral edema. We're worried about getting rid of that ketosis too quickly, causing inflammation and reperfusion injury within the brain. And so that comes back to making sure we watch that glucose, that we titrate the glucose based on our bag system, as we said, and start with a drip that is conservative. And if it is a high-risk pediatric, your standard rate is going to be 0.025 units per kilo per hour in those patients. So what are we evaluating consistently? Well, we're going to do serial glucose checks. Remember, in the transport setting, for those of you considering this, if you are putting yourself in the position of, okay, I'm transporting this patient, I'm on a ground ambulance, or I'm on a helicopter and I have standard capillary blood glucose measurement devices. Remember, anything greater than 500, your device is going to register as high. And so if your sugars are greater than that, if they're 700, 800, and although that is more unlikely in a lot of those patients, you're really flying blind or transporting blind as far as dropping that sugar. But we're going to continue to evaluate the sugar. We're going to continue to evaluate Glasgow Coma Scale. Do they respond the same? Are you seeing a decrease in their mentation? Those are all risk factors, or signs, I should say, of those high risk factor patients where we're trying to differentiate and watch for that cerebral edema. So based on that, what goes into cerebral edema in these patients? As I said, this is a really big risk factor for kids. And so it's an assessment area that we have to continuously focus on. And there's two areas that I think we have to always be careful of, and two areas that immediately put these kids at a higher risk. And number one, that's that low PaCO2. Remember, that's in response to that acidemia on that metabolic side, right? That patient is going to be tachypnic. That respiratory alkalosis is that opposite response based on what the kidneys are showing, that acidemia. And so what does a low CO2 do? Well, we know a hypocapnic CO2 causes vasoconstriction. Actually will cause a reduction in cardiac output, but it causes reduced cerebral blood flow. Vasoconstricts our vessels in our brain. What is that going to do to overall cerebral perfusion? It's going to reduce it. Couple that hypocapnic PaCO2 with a high BUN. And those are two factors that really should give you a high index of suspicion this patient has the potential. What would be a normal blood urea nitrogen, or a BUN? In the United States, it's measured in milligrams per deciliter, and that's going to be a range of 6 to 24. If you live outside of the United States, that's going to be right around 2 to 8.5-ish, and that's in millimoles per liter. And so, again, a low PaCO2 in combination with a high BUN, that is a independent risk factor that these kids could easily move into that cerebral edema state, or based just on fluid status, right? How quickly again, we give them volume in the very beginning, how quickly we reduce or get rid of that ketosis. So what are some other risk factors that we should always look at? Well, any patient that falls under the high risk factors, if they come into a level 1 pediatric facility, this is usually an automatic ICU admittance, right? They're not going to be sitting in the ED. So any child less than 24 months, so any child less than 2, any child that has any developmental delays, anything like that, any child that comes in or currently has a Glasgow Coma Scale less than 13, after volume resuscitation, again, after that volume resuscitation, and those assessments are happening constantly. Any abnormal neurological exam. So again, that's a pretty wide window. Any other organ dysfunction that may be perceived or evaluated. If you have a pH that's more critical, so less than 7.15, you have a bicarb less than 5. A lot of these kids, honestly, if they're late as far as in the stage, they can come in and have bicarbs less than 5, bicarbs of 1, 2, 3. Any patient with a PaCO2 less than 10, again, that's very, very low. A BUN greater than 30. And then have they received any bicarb? We're going to talk about bicarb or insulin already. Remember, we withheld the insulin prior to that initial bolus, that phase 0 resuscitation. That's where a lot of times we're going to come into play if you're a pre-hospital provider. If you're a HIMSS crew, hospital probably have already started the care, and that's where we see the bicarb administration, the insulin administration. And then lastly, do they have a serum Oz greater than 350? We know a normal serum Oz is between 275 and 295. And a great way to remember that is double your normal sodium level of 135 to 145, and that gives you that range of serum Oz. We know a higher number means you're more cellularly dehydrated. A lower number means you're more cellularly dehydrated or hydrated. And so it's always a ratio of solute versus that volume. What are some other risk factors that will guide us in our cautious approach? These are more treatment risk factors. As we've talked about in lots of podcasts, and I have talked about in other education, our ability to recognize acid-base balances is so important to our overall understanding of resuscitation, and we have to be able to easily identify that partially compensated metabolic acidosis. And so for this patient, right, CO2s were in that range that was alkalotic, and we had that CO2 of 24. Well, what if that patient's hypocapnia worsened? So a greater drop in CO2 after really adjusting for the degree of acidosis is a big red flag. If your BUN continues to increase, if that acidosis worsens. And another big one is really the slow increase in serum sodium. A lot of these patients have a low sodium. We're going to talk about that pseudo sodium drop and how to calculate for what's called a corrected sodium. But if they truly do have a drop in sodium and you bring that sodium up super slow, that is an independent risk factor. And what essentially happens is it's associated with a decreased effectiveness of your plasma osmolality. Another one is a greater volume of fluid administration during the first 4 hours. So remember, we're really guiding this fluid administration in a slow, methodical process, starting again in that phase 0. And then lastly, the use again of sodium bicarbonate for acidosis. Based on the probability of a pseudo hyponatremia in any DKA state. Now, this is not every single patient, and a lot of papers say this is more of an uncommon finding. It's the key is to evaluate it and be able to recognize it and adjust for it. And the way you calculate a corrected sodium is based on a formula. And the formula essentially is this. If you're taking note, in parentheses, I want you to write that serum glucose. So we had a serum glucose of 389 minus 100, and that's going to be in parentheses. Outside the left side of the parentheses, you're going to write sodium plus. And on the far right of your parentheses, you're going to multiply by 0.016. So 0.016. You're going to make sure then you do the order of operation. We're going to do the parentheses first. So I'm going to take 389, our glucose, subtract 100. So we have 289. That's going to sit in the parentheses. We're going to multiply next. So 289 multiplied by 0.016. And that should give you right around 4.6. And then you're going to add the sodium onto that, which was 125. And that gives you, for this patient, a sodium, corrected sodium, of 129. We can round it to 130. Now we know that's low. That's a lower sodium. Remember, sodium levels are 135 to 145. Is that something that we're going to worry about? So how are we going to manage, once we know the corrected sodium, how do you manage that from more of a resuscitation or ongoing resuscitation standpoint? And you're going to look at this again based on how it's trending. If that corrected sodium, for example, trends downward or falls below 140 milliequivalents per liter, then you're going to adjust your maintenance fluids to contain normal saline and increase the frequency of your lab testing, specifically looking at that sodium. And taking it a step further, if let's say that sodium decreases or that corrected sodium comes in less than 130, then that's where you can start being a little bit more aggressive. And again, this is going to be protocol dependent, but if you're using a peripheral IV, they recommend 2% normal saline. If you're using a central line, you could go 3% normal saline. But a corrected sodium of 130 or less, then, that's where you need to maybe consider treating that. I definitely would, identify truly the need. I would definitely discuss this before you went that route. If we then come back to our resuscitation phases, we had phase 0, that's that really pivotal area where we want to make sure we watch our fluid management. We use that 10 mils per kilo. We had phase 1, that was that 2-bag system that really is from that 1 to 4 hour mark. And I think a lot of these patients are going to fall into that time period. And then we have phase 2, and that's going to be 4 to 48 hours. I'm going to include this algorithm. This is by Seattle's Children's Hospital in the show notes where you can download this and look at this. It's, I think, pretty good, well made. The last thing I want to really focus on is why no bicarb? That's always the question, right? Severe acidemia. Do we give bicarb? Do we give bicarb? And really, in the essence of how bicarb affects the patient, right? When you read the studies, and I'll include a study on this, there's been no indication, there's been no RCTs that demonstrated any improvement in outcomes or that it does anything of any good. But in essence, really, the mechanisms are multifactorial, right? You have already that initial cerebral vasoconstriction that is reducing that blood flow, right? We have acidemia, we have the hypocapnia. You also have a potential with that bicarb administration of a cytotoxic edema. And a cytotoxic edema is really the result of cells being unable to maintain ATP, right? We've talked about ATP production in other courses, but really ATP is dependent on a properly functioning sodium-potassium pump. And that cell's ability to have a membrane that maintains just that. If we don't have a good sodium-potassium pump, essentially what happens is the membrane, which are responsible for keeping a high extracellular and low intracellular sodium. Remember, your dominant extracellular cation is sodium. Your dominant intracellular cation is potassium. So you don't want as much sodium into the cell. You do want potassium into the cell. And so that membrane, that pump maintains that proper sodium-potassium gradient. Again, a high extracellular concentration and a low intracellular sodium concentration. And essentially, when the energy falls, remember that's dependent on that ketosis. As in the case of a patient that has cerebral ischemia, then the pump essentially stops working properly, and you have sodium that accumulates within the cell. We don't want that, right? That should be dominant extracellular. Causes that draws in also swelling. Chloride. It causes a reduction of extracellular volume as well. And really, it comes down to bicarb is not the fix-all, right? Bicarb, especially in pediatric DKA patients, is not something we want to focus on or mess with. There's no evidence to support it. If anything, it worsens outcomes. Hopefully this podcast was educational. These patients are different than adult DKA patients. And really what I would challenge each of you listening is to consider your role in taking care of these patients. If you're an ED nurse, you have a role. If you're a transporting nurse, if you're a critical care paramedic, if you're a critical care nurse working on a ground truck, if you guys are flight nurse, flight paramedic teams, you each have a different role. You may see the patient in different elements of, remember, phase 0, phase 1, and I really left phase 2 for you to look at the protocol, because I think a lot of times from 4 to 48 hours, you might not really have these patients in that area. As always, if you have any questions, if you have any new case ideas, any new topics that you want addressed, please email me at eric.bauer@flightbridgeed.com. If you haven't already registered for Fast 22 in Las Vegas, Planet Hollywood, it truly will be epic. It's like a conference that you've never experienced, I promise you. We try to do things different. We understand that education needs to be delivered in a certain way, a special way. We try to do that. We really try to be innovative. So check it out, fastsymposium.com. And I look forward to seeing you. Again, reach out if you have any questions, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.